got it here at my previous employment. He's now at Beaumont doing...
Actually, on the medical board, office is completely different. Non-clinical administrators are boring.
But in his past, he came to us from Dallas, and he did a lot of teaching at the medical schools there. So he is going to enlighten you on lab work.
Hi, how are you all? Probably not. Let me just start by saying that it's been a little while because what I'm doing now is mostly disability evaluations to the wounded warriors that come back from Iraq with the IEDs and maimed and wounded. We treat them, evaluate them, and send them over to Oklahoma, Washington, where they do evaluations. So I'm really not doing any treatment right now. So I'm a little behind in my drugs and everything else. It's been, what, about 6 months now, almost? So I hope you all will just bear with me. I like to do, the way I do things when I'm assistant professor of family medicine at UNT Health Science Center, TCON in Fort Worth. And with the fourth years and PGY 1s, 2s, and 3s, the way we used to do it is very informal. I mean, I don't like computers. In fact, I think it's like, I hate them. That's all I have to do is sit there and look at computers and use all those military insignias and basic security levels, and it's driving me absolutely nuts. Then we've gotten away from the human contact. So I try not to use pointer and all that kind of stuff. So what I did is I just wrote down some stuff that might be helpful to you. I'm sure I'm not going to say anything that you all aren't familiar with, but maybe just to kind of reiterate some things if you have any questions. I'm really, by choice, I'm a family practitioner, general practice. I do a lot of occupational medicine, and I've done some disability work. And so I, do a little bit of everything. I really haven't done a lot of pediatrics in a while, as Kathy could testify. So I've been, when I was treating patients, I did a lot of geriatric stuff and adult medicine. But generally, for laboratory evaluations, I always start off by telling, when I was teaching the students over, the medical students at PCOM, by telling them that, in my opinion, my personal opinion, in general practice, the most important thing that a clinical provider can do is take a thorough history. I am not a physical exam guy, and this and that, and learning all these murmurs and all these different signs, because you forget them. Unless you're doing them over and over and over and over and over again, you're going to forget them. But if you can learn how to be a good history, taker and evaluator, and even more important, a good listener. And excuse me, Kathy, are these nurse practitioners?
They're all nurse practitioners, okay. And they should be graduating and looking for jobs in December.
Wonderful. I was co-medical director at the Agape clinics in Dallas that were founded by nurse practitioners. So I have a special love for nurse practitioners. Our school has a PA school for, which is a master's program that you get on top. And we're trying to incorporate maybe getting the nurse practitioner school there too. But again, I've been gone for about 4 or 5 years, but I'm kind of partial toward nurse practitioners. So for personal reasons. Well, I'll tell you what, no, bottom line, and I know, we're getting off the subject, but that's probably good because I don't have that much content. But politically speaking, I'll tell you what, there is a big difference. Don't let anybody tell you PAs, nurse practitioners, oh, there are mid-levels. No, there's a big difference. And in my opinion, you guys are very much better instructed and you're more teachers. PAs are good technicians. They're really good in procedures because they follow the physicians. I mean, we taught them with the 3rd year and 4th year medical students. So they get the clinical basics, they do a little bit of clinical basics, but it's mostly basic science, boom, clinical sciences, and they're out there. And if they don't hover right to a physician, there could be some lacking there, I think. And I came from a school that's what we have, PAs there. But the nurse practitioners, usually you have the experience behind you, and you've got that teaching quality that you're innate inside of you, that to me, I think it's a little bit better, especially in a teaching environment in an ambulatory care practice where patients want to know what's going on. So that's my own personal preference on that, on take on that. Although there's some wonderful PAs, don't get me wrong, I'm just kind of partial towards you guys. But having said that,
I'll pay you off later. You gotta go too. Yeah.
But having said that, as I said before, the most important thing in my opinion is taking a thorough history and being a good listener. Unfortunately, people, and one of the reasons why I got burned out and I started doing administrative work is because insurance companies won't allow you to do that a lot. It's just the way it is. And so you're torn between seeing this many quotas a day and trying to do a thorough job, and well, let me just handle the first two major complaints, we'll have you back, and this and that, and each one of you will learn how to best cope with that. Everybody's different. You can be totally different from me, you're totally different from Kathy. Every person has to learn their own way of dealing with that. But remember, time, and time management is where it's at in this world. And unless you're independently wealthy and you can start your own practice and you don't care how many patients you see, then you're going to have to budget yourself. One way or the other, you gotta do it. Okay, so that's a given. But having said that, most of the time I found that if you listen to the common afflictions of your patients, they will tell you exactly what's wrong with them. Okay, now you will get some lingerers, and you'll get some people that just like to come in and see the doctor. You're always going to get those. But for the most part, in today's time, especially with HMOs and everything else, everybody's busy. If you take the time to listen to what their complaint is, a lot of times history will tell you pretty much what you need to know. The physical, hands-on stuff is just pretty much to confirm. That's the way it's been with me, at least for the most part. Don't be in such a quick hurry to start ordering it. Anything and everything you can think of to help you formulate a diagnosis. There are a lot of the medical students over at Lord have mercy, William Beaumont Army Hospital. My God, they want to order everything under the sun. And of course, with the military, they're not under that big of a budget constraint. But in private practice, believe me, it makes a difference. And my understanding now is some of these health insurances start taking profiles on you. And they keep profiles on whatever you order. And if you order batteries of this and batteries of that all the time, somebody's watching you, okay? And that can come up later when they select you or deselect you or whatever when you apply for certain programs and insurance companies and things. And again, that's them practicing medicine on us, but what can you do? So you have to be very prudent and cost effective. It's very, very important. And a lot of times it's not necessary to do a lot of labs. Labs are primarily confirmatory or to help you already formulate what you feel is going on, okay? My motto is this: as a primary care doc, I don't try to know everything, I don't try to learn everything. I try to spread the liability. I've told Kathy that a lot of times. She's heard me say that. I am not the expert. I don't pretend to be, don't want to be. If ever there's a doubt, when in doubt, what do? Absolutely right. Now that doesn't mean you have to be a triage nurse. You didn't say that, right? Okay? There's a difference. Somebody refers everything because I'm not saying that, but don't be afraid to refer. Do not be afraid to refer. I do it all the time. And I surround myself with competent specialists. That's another thing. You have to know who you're referring to. Because when you are the PCP or the primary care, patients usually think of you as being the provider. Well, that's the surgeon, or that's this, or that's that. And they come back and they tell you. They tell you if they had a good or pleasant experience or a poor experience in that situation. So it's up to you, it's incumbent on you to know who you're referring to. It's very difficult now because you got to go through the HMOs or whatever else, there's insurance policies and see the list, and a lot of times you don't know the docs, but try to make it a good habit to try to surround yourself or know a little bit about your specialist. It really makes a difference. Plus, there's a good rapport there, and you learn by referring how they treat certain things, and then a lot of times you can pick up that art and do some of those things yourself. So you know, but anyway, that's kind of like an intro to what I'm talking about. As I was saying, the first thing is, you first you want to go with the signs and symptoms. And, in general, if you're talking about an adult, middle age or even older, they'll come in and say, well, I'm urinating a lot, or I'm hungry all the time, or I'm tired, or I'm thirsty a lot. Of course, you might be thinking about some endocrinological problem like diabetes or something like that. Well, at that time, you ask them, what is your history? Have you been seen by a physician before? When was your last blood test? Is there a family history of? It's very, very important. I always ask that if I'm thinking of any kind of potential metabolic problem, that could be a genetic predisposition there. And I'll ask them that. Sometimes they'll know, sometimes they won't, but a lot of times they'll say, oh yes, my mother has diabetes. My dad, I think he died of a heart attack, but he had diabetes or something of that nature. Well, that's a big clue. Second thing is look at them. Just take a visual look at the individual. Are they overweight? Do they have central obesity? They may be overweight, but be proportional down here, and they're more fit than you are. Okay, but do they have central obesity? Do you see that little brown line across their neck, acanthosis nigricans? Do you see that? Do they have rings around their eyes, preorbital edema? Are they kind of puffing and huffing, kind of like what I'm doing now? Are they doing that? Do they smoke? On and on and on. Do they drink alcohol? All these things are history taking. All these things are important clues. Now, the basics, some of the things that you get are generalized malaise, generalized fatigue. That could be a million things. And they'll ask, well, doctor, I've got this, and I've only had it for about 7 or 8 months, and what do you think it is? And they want the answer right now. And so, you have to kind of let them know that, well, we might need to do a few more tests and do a little bit more examination and things before we know, because a lot of those things are so generalized, they can fit 50, 60 diagnoses or more. And you don't want to be too quick to say, well, it could be this, could be that, could be this, because you don't want to get them upset about that. So you have to be patient, and that's what I'm saying, and that's where the problem comes, because society tells you to get them in, get them out. Get them in, get them out. You got a 20-minute, 25-minute slot there, and they're probably 5-10 minutes late on top of that, and this and that, and something else happened. You got bogged down with something else. So you see where I'm coming from? It's a problem. And there's no cookbook answer. If there was, I'd give you the book and say, learn it. There isn't. I've tried, I've looked, and you just gotta figure it out and go with what works with you. Go with your personality, okay? And some people are very touchy, friendly, get to know them, and then get into the medicine. Some go right into it, but do it in a very warm and friendly way. Doesn't matter. Does not matter as long as the job gets done. But you have to work that out for yourself. You can't depend on somebody else to show you that or emulate somebody else because it seems like it works for them. It may not work for you. You may not be that type of personality. You may not be a type A. Maybe a type B. I'm a type C. I'm so laid back, I fall on my head. But, like I said, it just depends on how you do things. But basically, you look at the signs and symptoms, you look at the individual, obviously vital signs are there, but, and some of the basic, and that's the only thing I really kind of keyed in on, clinical observations is, do they have the cholesteatomas on the eyelid? Well, maybe hyperlipidemia or some type of tumor. When you feel the belly, are you feeling hepatomegaly or organomegaly, splenomegaly? Do they have that CDA tenderness back there? It could be lumbosacral-discogenic disease, or it could be a somatic dysfunction, myofascial dysfunction because, a back problem, or it could be kidney, flank problems. You don't know. A lot of times they don't know. And if you ask them the classic stuff, they'll always tell you to know. Well, do you have burning on urination? I don't know how many times I've asked a person that had a UTI. Nobody has burning on urination that much anymore. If you're waiting for that answer, forget it. They'll come up with a million other things. Well, I got a little bit of pain down here, a little bit of back pain there, or but they won't tell you that. So you see, that's why a lot of times talking to the individual and getting your basics. Pretty much everybody that comes in that may be suspected of any kind of metabolic problems should have a general UA. I mean, I get that on every female from 4 to 80, if they complain of chest pain, I still get, well, where are you getting that, Gordon? I mean, I didn't see anything down below. You'd be surprised. A lot of people come in, a lot of women come in with chest pain, they're coughing, you think it might be a cold or something, but they have a little, they'll say it's pleuritic, kind of like, and they'll say, is it down here in the belly or down below? No, 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 it's up here, epigastric. Well, you think of GERD, you think all the other stuff, but get the urine. Just trust me, it doesn't cost much, won't cost you a few cents to get a urine, you'd be surprised. Bingo, white blood cells, blood, they got a UTI. I don't know how many times that has happened to me. Now that may not be the only problem, that's one of the problems. So you'll be surprised what you can get in there. Of course, asking the questions, you know, removing the fact that they're on their period or anything like that. But it's very, very helpful and it's very cheap. Next thing that I can go over is like, you asking, you know, drinking, smoking, you know, drugs. Most people will deny drugs. They may say, I may do a little bit of marijuana here, there, and there. But, you know, if you can get a true history, that'll kind of help you look at, is there some problem in the plural aspect in terms of if they're a heavy smoker, especially if they're complaining of malaise and fatigue, you know, bronchitis, bronchitis, seasonal allergies, you know, all kinds of things. You know, in different seasons, especially here in El Paso, all those things, you know, could be suspect. Do you go out and start doing a whole lot of lab tests? I wouldn't, because probably most of them are going to be negative. And again, you're building up that panel, somebody's got to pay for that. And that patient, when it's turned over to the insurance company, you're looking, oh, they did a RAS test, why did they do all that? They didn't know, blah, blah, blah. And then you find out that it's just seasonal rhinitis. See what I'm saying? So don't be too quickly to jump to all these tests in the initial onset. For a general metabolic problem or suspected metabolic problem, I always will do a CBC with DIF. Of course, that's, you know, that's basic. You ask the individual, have you had that done recently? Well, I just had it done a couple of months ago. Well, they had it done a couple of months ago. Get those results first, unless the signs and symptoms are very acute. You may save you some time at ordering, you know, stuff that you don't need. But a CBC with DIF is important to get. You know, you don't need a peripheral smear unless there's some immunodeficiency problems that you're suspecting. I'm always sick. Every week I come down with something. Every week I've got this, I got that. Kids bring it into me, blah, blah, blah. What's the first thing you'd ask a person if they tell you, I'm always getting sick, I'm always coming around with respiratory infection?
Their first year in clinical as an FNP student?
I'd be the first one, we'll be the second one.
Is anybody else sick in the family?
Exactly, very good, exactly, the association. Second thing, what's their emotional status? What is their emotional? Absolutely. I am a firm believer, stress will kill you faster than cancer. I can't prove it, but I believe it. So, if they're depressed, they come in dysphoric, and I notice a lot of females, women, that I have seen will never come out and say, yes, I'm depressed, but they'll give you a million signs and cues that they are. You know, well, I'm a little anxious, oh, the kids are this, and you know, it's just so much work to do, but are you depressed? No, I have a great life, great this, but this, and then they'll go on and on and on and on and on about things, and bingo, you find out. Generalized anxiety disorder / stress, dysphoria, possibly dysthymic syndrome if they're complaining of a lot of back pain. And let me tell you, number one diagnosis now, I think, that has been sent to rheumatologists that they're finding out is fibromyalgia, believe it or not. And when I was in school, that was like a wastebasket term. We didn't really know what to do with people with fibromyalgia. Still don't, really. I've got soldiers coming in from Iraq, and the majority of them, you probably heard of them, PTSD, big time. Minimum traumatic brain trauma. They're coming in with that, along with, of course, all the musculoskeletal problems that we have to deal with. Fortunately, I don't have to deal with that because that's under the DSM-4, and you got to go through all the axis 1, 2, 3, 4, 5, which is not bad to learn and be familiar with because it kind of helps you when you're looking at, you know, some of their other illnesses. If you can kind of see what's going on, what is axis 1, what is the chief personality disorder or whatever, axis 2, what do they have a childhood personality disorder, axis 3, what is their organic problem, axis 4, what is their global assessment functioning, all that kind of stuff. it helps. But the fact of the matter is, with stuff like fibromyalgia, you may be looking for red herrings there, and you may never find it. You can do $200, $300, $400 worth of labs, complements, rheumatoid, arthritis, RF, ANA, speckled cells, autoantibodies, the whole 9 yards. You may get 1 or 2 that are positive. So what? What does it tell you? Does it diagnose it? No. You got to look at the whole person. Are they depressed? Do they have multiple trigger point tenderness? You know, how many do you have to have supposedly for fibromyalgia?
10.
Nope. Got to be between 15 and 18. Yeah, and they're usually, and it has to be on both sides, symmetrical, both sides of the body. Can't be just here, 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 thigh, legs, arms, all that stuff. No. It's got to be both sides, and it has to be upper and lower trunk. And a lot of times, of course, down the spine, you'll get them there. And it doesn't have to be associated directly with the joint. Because remember I said it can be myofascial, so your muscles too. But generally it has to be somewhere between 15 and 18 trigger points, okay? And they have to have gone through multiple medical regimens with treatments. Everything from analgesics to possibly antidepressants, and now we're starting to use that drug called Lyrica. You all familiar with that? Okay, you know how that works. And that, along with some of the atypical psychotic medications, we're using that a little bit, Cyprexia and stuff like that. And even with all that, it may be improved, but they still have the symptoms. And then once you've ruled out the rheumatoid arthritis and things like that, then by default, they become fibromyalgia. You have to rule out all the neurological, muscular dystrophies and all that stuff. No atrophy going on. They're not having fasciculations, tremors, stuff like that. But it takes a while. And most people aren't going to do it in one visit. Most people aren't going to do it probably in 2 visits. You know, so, and that's when you're ordering your labs. That's when you're doing your EKGs, you're doing your chest x-rays, and you're examining that person musculoskeletal-wise. And they're telling you, because remember, they can be migratory, they can shift from one area to the other. This time it was my arm, now it's my chest wall. And then this week, oh, now it's my thighs. You know, so it can migrate, but they're still there, and they're trigger points. It's not soreness. You can just kind of point there and kind of twinge. And see, that's just one example. But these are some of the things that are kind of difficult sometimes to put a lid on. And a lot of people may have already diagnosed them with depression. That's an easy diagnosis with somebody when you can't figure out what it is, and they don't look too happy or pleased. Oh, it's depression. It's depression. It's dystonic syndrome. It's depression. Somatization. All this stuff. But, you know, it's basically just sticking to your guns on that. But anyway, as I was saying, CBC with DIF, I always like to do liver function tests, you know, the ALTs, the ASTs. We used to call them SGPT and SGOTs. That's the old-fashioned way. The most specific one to the liver, of course, will be your ALT. And so that's when I look, if that's rising higher, then I kind of think of more liver problems. If I get kind of a mediocre rise in the SGPT, but the SGOT is kind of pretty high, then I'm kind of thinking of bone problems, Paget's, or some kind of calcium problem. So I'll make sure I get a calcium battery. And then, of course, you want to get your electrolytes, your sodium, potassium. Remember, low potassiums, you know what that means, malaise, generalized fatigue. God forbid if they have congestive heart failure and they're on lanoxin. Ugh, bad news. So you got to do all that stuff, you know, low potassium. Lanoxin becomes toxic. What happens? Or what can happen?
Increased heart rate.
Yeah, and? Well, yeah, ventricular, you go into arrhythmia. Yeah, exactly. So you got to be, but fortunately, I don't think there's a lot of people on lanoxin. Some of the old cardiologists still put them on there. It's still used, but fortunately, it used to be when I was in school, you had to titrate at that certain level, and you had to make sure it was right there. It was a narrow therapeutic yield, they said, right? Now they're saying even just a little bit of the stuff will improve contractility. You know, and how does it improve contractility? Shifts the Stirling curve to the right. Remember that? With contractility, it moves the Fred Starling curve. Y'all remember that? You know that stuff, right? Increases the ventricular contraction, right? So that's how it works. But you don't have to have the major dose levels now. You can do a little bit at a time. So that kind of helps you out if you have somebody that's on a diuretic like a loop diuretic or a thiazide or something where, you know, they could become hypokalemic. And I always will put them on a little bit of potassium supplements if they're on any kind of diuretic. Say a thiazide. A lot of times you don't need it, sometimes you may. But the electrolytes are very, very important. There, nobody will fault you if you get a little antsy and get electrolytes maybe once a month for a while or something like that. Who's going to fault you for it if the person has a known history of heart disease and or electrolyte imbalance? Nobody's going to fault that. They may not like it, but they're certainly not going to cite you on it. So do what you got to do. You know? So moving on. And by the way, any questions, please stop and ask me. The fasting lipids. Oh, that's another thing. That I had a problem. I don't know if Kathy has seen that too with kids, but a lot of times, first-time visits, if you don't train the front office to tell them, please come in fasting, just in case. Because a lot of times when they come in, you find out, you see them, they come in for a cold or something acute and sweet. You find out, oh my God, this person's got some other things I need to find out about. Well, I need you to come back for fasting. And immediately, what is the first thing that patients want to think? No. I wish they would, but they don't. He's trying to make money off me. Here you go. Now he's trying to make money off me. I've heard him say it. Okay, that's what they think.
And you'll only get about 25% of them back, if you're lucky.
That's exactly right. That's right. So it's always a good idea if you can have them come in fasting and even have the blood work done if you can train your office or to do that, unless it's something just, you know, an introductory, something or it's a young person that you don't suspect anything. It's really good to do that because then you have to come back, you know, 24 or 12-hour fasting, come back, get the blood work. It takes about 24 hours. That's not a big deal, but then you got to bring them right back. And so that's 2 or 3 days. A lot of people get turned off with that because they got to pay a copay usually and this and that. So, and even if you find something wrong, you know, still, you know, they're not that cool with that. Let me just put it to you that way. So that's another thing. So be intuitive. You know, kind of think ahead. Well, I need this. Can I afford to have this patient just come back in a month or 2, and then we'll set him up for a general physical at that time. At that time, we can get the fasting blood work, which would be the ideal situation. But a lot of times, you don't have that luxury. So, especially if they're elderly people, and if they haven't seen the previous doc or whatever for a while, and usually they know that they need blood work, but sometimes they have to be reminded. So, anyway, the fasting lipids are very important for obvious reasons. You know, it's just something good to get with your electrolytes because you're trying to rule out any kind of dyslipidemia along with the other metabolic problems that are there. I always throw in a basic TSH, all right? Even if there is no hint of thyroid problems, no hint whatsoever. You'd be surprised. There's a lot of people walking around with subacute thyroiditis, all right? You know, subacute means that, you know, they have very minimal symptoms. And the TSH may be even normal, but the T4 is off a little bit. Or vice versa, the TSH may be elevated because it's kicking the thyroid to pump as much of it as it can, but it just can barely get you thyroid levels. So what do you do in a situation like that? Do you leave things alone and just let them plug along? If they're symptomatic, I treat them. I don't treat labs. That's probably, if I had one thing to take home, that you all could take home from what I'm saying is, don't get in a habit of treating labs, because you'll go wrong every time, okay? Treat the person. I don't know how many times I have seen patients, little old ladies that will come in, and they are just rocking and rolling, and they're feeling fine, and they're on 25 micrograms of thyroid. And I'll do the lab test, you know, every 6 months, you kind of wean them down to it. And then the TSH will be just, I mean, it's just shooting up there pretty high. But the T4 and T3 are kind of a little bit about normal, you know, but the TSH is real high, so it's filling in. It's, you know, I need to add a little more, I need to add a little more. And I'll talk to them and I'll say, how do you feel? Oh, honey, I feel just wonderful. That's wonderful. Well, why don't we just kind of add just 17 micrograms more? So you go from 25 to 37, you know, you go up the step ladder, right? You know how to do that, and you let them, and they come back in 2 weeks. Oh, my heart is palpitating. I feel I have headaches. What did you do to me? My skin is, you know, Well, and you never would have suspected it. And in a younger person, no biggie, they would do fine. But in an elderly person, it made a difference. So a lot of times, just because the labs don't look like we want them to look, that doesn't mean you need to tamper with it. And that took me a long time to learn that one too. But, you know, again, it happens. It happens. Any questions so far? Yes.
No, that's
Oh,
good.
okay.
That's good.
With diabetes, when you're looking at diabetes, that's one of my pet peeves. I kind of like that subject. I thought I was pretty good at that on an ambulatory basis. You know, you can do that GT glucose tolerance testing if you think you need it, you know, but it's an inconvenience to the patient. If you set them up to do a fasting, and they come back in with, 226 or something like that, I mean, for all practical purposes, they're diabetic. You know what I'm saying? If you want to go ahead and do it and confirm it, that's fine. And a lot of insurance companies demand that you do that, because you don't want to be writing on there. Diabetes mellitus type 2, when they might just be glucose intolerant. Although a lot of people say glucose intolerance is the same thing. It's basically you're diabetic. It's just adjunct. So, but nevertheless, it's a good thing to confirm to get a glucose tolerance test 2 hour. I don't mess with the 3-hour one unless there's just a question about it. I will always do hemoglobin A1C. Do I do that for diagnosis? Of course not. You all know that it cannot be used to diagnose a person. Unless, of course, they come in with a 350, and then you just go ahead and do a hemoglobin A1C, and you see it's like 12. Well, it's obvious. But that's not why you made the diagnosis. You made it because the sugar was so high. But it's still good to get because you get a baseline, and then every 12 weeks, I try to do that. If they're uncontrolled, I have them come back and repeat it 12 to 16 weeks. And it just depends on where you're comfortable at. If they're very, very uncontrolled, you might want to bring them in as much as every 12 weeks. But the literature, I think, says 16 weeks or something. But I'll bring this more. Because remember, red blood cells turn over every, 121 days? Yeah, so that little glycine polypeptide on it that carries that little glucose sugar there, it carries it until it dies off, and then it shifts it over to another one. So that's how we kind of like know the hemoglobin A1C tells you what you've been doing over the last 12 to 16 weeks. If they have thalassemia, forget it, can't do it. If they got sickle cell trait, forget it, can't be done because the hemoglobin molecules aren't enough to do it. But save that. It's a very, very, very good test that I use, on a normal basis for all my diabetics. Even if they're very well controlled or if they're very poorly controlled, doesn't matter. Whether they're on insulin or they're on total orals, I always try to get that. And once I get them straightened out at the desirable level, which is usually below 7. Actually, I like to shoot for 6.0, but and we're still kind of behind. I think the guidelines will change pretty soon. It really should be kind of like 6.0. But the literature will say if you can get on 7 or less, that's reasonably good, reasonably tight control. Then you can kind of back off. Remember with the diabetic medications, I know I'm kind of going through all that too, but just I like to be complete. I like to start off with probably metformin and or the new drug, which is Januvia. I don't really like the sulfonylureas too much, unless it's a very young person and there's no chance that, there's a reasonable chance that he's got a great working pancreas, he or she, and that he's not already burned out a lot of those pancreatic cells. You start hitting them on the regular type 2, second generation, first generation oral sulfonylureas. You may kind of help control the hyperglycemia, but you're really burning out that pancreas. And so later on, I think it's our opinion when we did some research over at the school that you just basically you're just gearing them up to put them on insulin. So don't get me wrong, it's still a great drug. It's still a first line. The sulfonylureas are still first line. But I usually go with the metformin and or like something like Januvia, or I might even use the triglycerides. The problem with the triglycerides is that if you use the Actos, if they have a lot of weight gain, it's going to make them gain more weight. So you got to really have them get on that diet, okay? But the good thing about it is a lot of people with diabetes also have concurrent hyperlipidemia. So it brings down the triglycerides and it increases the HDL, which is a very good thing. Okay, if you want, yes, ma'am.
Is the weight gain due to the edema?
No, it literally, they think that the triglycerides literally just, for some reason, it also causes weight gain. And you would think it would because it reduces the triglycerides. But some kind of way, because it works intracellular, inside the cell, you know, it doesn't, and it works in the nucleus, makes receptor sites to bring in the sugar faster. That's the way it works. It also brings in other stuff, we think, you know, and it causes the metabolic rate to slow down to where you can gain weight. Now, it doesn't work, not everybody, but that's just something that you need to be aware of. And of course, you have to be aware of liver function test with that drug too. But it's not so much water weight. The diuretics, you can always use that to kind of counteract that. With water weight, with diabetes, if they're females and if there's an endocrinological problem, hormonally, and they're young enough where they, you know, their periods are irregular, then you can always look at some of the glucocorticoids, you know, but you have to be kind of careful with those things too, because sometimes that can cause problems too. But a lot of times that works along with it. But you have a lot of things at your disposal when you're talking about medications for diabetics. The ascorbyls, the thing that prevents people from taking in sweets because of the reaction. I don't like that. There's too many side effects. I haven't met one patient that could use that stuff, even though it does work. And it's, you know, but the side effects are just so bad that it's not really sold that often. So, but and then of course, you know, if you have to, you know, you have to use your insulin. You know, you have it there. As far as tests are concerned, most important thing, second to what I just told you before, is with the diabetics that aren't that obvious. That's, I mean, I'm not talking about the one that comes in with the 300 and you know they're diabetic, their A1C is like 10 or 11, and you say, oh, this person probably needs to be on insulin. Yeah, why am I fooling around with orals? I'm not talking about them. I'm talking about the one that comes in with maybe a 7.4 hemoglobin A1C, but they're definitely confirmed by glucose tolerance tests as being diabetic, and their fasting may be, I don't know, 150 at one time or something. Not that bad, you know? And you look at them, and they look okay, but they kind of complain a little bit of a little numbness here, a little numbness there, but no big deal, just a little numbness there. What is that a sign of, possibly? Peripheral neuropathy, absolutely. And what is that a function of? Peripheral neuropathy. Microvascular disease versus macular vascular, okay? The macular vascular disease, you'll see it. They'll come in there with the heart, the big heart, and the problems with, you know. But with microvascular disease, the best way to detect that, as far as I'm concerned, is still good old microalbumin. So everybody should get a urine microalbumin and check to see if they're spilling protein, because that's a very good indicator of early microvascular disease. They may be perfect, foot exam, perfect, no cutaneous skin changes, nothing. They're slim, body proportional, everything's fine. You start spilling some protein in there and they don't have any problems urinating, no problems there. That could be an early sign. So, and that's when you want to add on what drug? Absolutely, or exactly right. When would you do an ARB over an ACE?
Well, it depends if they don't.
Side effects would be one, right? The literature will tell you always go with the ACE first, but you know what? I do ARBs first. I like ARBs better. And I'll tell you why. I get better results from them. Can you use them synergistically? Yeah, you can do it. You can actually use them both. Now you may get a problem with the insurance company. They'll kick it back at you and say, why are you doing that? But in some cases you can justify that, you know, but I won't go into all that. But the ARBs and the ACEs are very important. If you got the old cough syndrome and stuff like that, then you may have to. But always think about putting them on a low dose ARB. Blood pressure is perfectly fine, don't matter. Just put them on a very low dose and protect those kidneys. Very important on that. All right. Any questions on that? Another thing that I found that kind of helps out that I throw in, getting over myself here, but I use the omega fatty acids. Excellent. What do they call Laveza? I think they changed the name to Laveza now. Now, you will get all kinds of nightmares from insurance companies. They don't like you to write that drug because it's expensive. Yeah. And the literature says that you need to take 2 BID. That's 4 of those little gelatin deals twice a day. I found out that 1 twice a day will bring down triglycerides probably about 60, 70 points. Yeah, down. And a lot of times that's all you need. But, you know, for dosing purposes, when you start, you know, dividing it, having it, sometimes you get problems with that. So, you know, I tell them, well, just start off with that and just hold on to the others. Yes, ma'am.
I have a question. When I did my clinicals in the summer, we were talking about the omega-3 fatty acids and the ones that are prescribed and the ones you can buy over the counter. And then Dr. With said that he didn't notice a big difference on the ones that are prescribed and the ones you buy over the counter, that they both brought on the triglycerides.
Big difference. Disagree. You can go to GNC, and if you don't believe me, go to any GNC and say, I want the omega fatty acids. And they'll show you a list that'll cost you $150 here, and then they'll show you another brand that'll cost you probably about $35 a month. And you tell me, is there a difference? It's not FDA regulated. They can put fillers and all kinds of other stuff in there. You never know. So, yeah, in my personal opinion, yes, there is a difference. It's just like saying if Kathy puts a person on Synthroid and then they leave Kathy and go out of town and go to another doctor and he puts them on a generic levothyroxine, same microgram, is there a difference? Yeah, there is a difference in some people. You believe it or not, it's the same chemical, but there's a difference. So yeah, I would go with the prescribed if it's absolutely needed. If you're doing it for a health reason, just to be healthy, the over-the-counter is fine as long as you read and you get the better brand and you know what else is in there and you talk to the people, the pharmacists who direct you and you know what else is in there. But otherwise, I like the pure prescription portion of it. But it's expensive. I think it costs like 140, 130, something like that. So it's a little higher than the statins. So it's, you know, it's up there. But, you know, it's a good drug. It's for healthy living. It's a great medication. So.
They have a scholarship plan, I think.
Pardon?
They have a scholarship plan for the patients that can afford it.
Is that right? Really?
And it might be the only thing you can give a pediatric patient under age 12.
True. Definitely, because statins are definitely can be problematic there. You know, but meds that alter lab results. I want to just touch on that. There are tons of them. I'm not going to go through all of them because I don't know half of them. I don't know a third of them. I don't know a tenth of them. But the ones that I've had problems with them are the atypical antipsychotics. Whenever you see somebody that comes in, they may be a little overweight, and they have a history of bipolar and or schizophrenia or something, and they're seeing their shrink. And of course, you know, a lot of people don't want to tell you a lot of information on that, and a lot of times we don't want to ask a lot of information. As long as they know that they're following up and that they're taking their meds, that's good enough for us, right? Come on, let's be honest, right? Right. We don't want to deal with it. We don't want to deal with it.
Except for Laura.
Okay, Laura, I'm with you. They tell me everything.
Well, guess what? If they're all that, you gotta kind of be interested a little bit in it because, you know, those drugs can tip them off toward diabetes. You gotta watch that. So you gotta at least be monitoring on a periodic basis their blood sugars on that. Nicotinic acid, that's another one. You know, to lose the triglycerides and build up your HDL. It's a pretty harmless thing. Get it over the counter, no big deal. Only thing you gotta worry about is a little fleshy out here in the Sun City, turn red and all that. Well, like you can.
Flesh-free.
Pardon me?
There's flesh-free.
Well, yeah, the long-acting, the delayed one. True, it is. But an easy cure to that is tell the patient to take it, and then 1 hour later take an aspirin. Goes away. Now, I wouldn't tell them to get right out in the sun when they take it, but usually that works. but the nicotinic acid can also mask the effects of sugar, and it can come in, so you have a problem there. When I was sitting here in your OC as a student, medical student, it was the act of heresy if you gave a diabetic a beta blocker. That was as bad as giving an asthmatic a beta blocker, right? Now it's done all the time. It's one of the ornaments. That's what they put them on, you know? Can you believe that? So it just goes to show you, but I think one of the reasons for that is that they've made it so cardioselective that you don't get some of the other effects that beta blockers can do. So it's really now you can do that, but you still should be very cautious when you do it, I think. Obviously the glucocorticoids could be a problem. Somebody has arthritis, and oh, my knee is flaring up. Oh, what's your sugar? Well, it's about 220. Yeah, I know. But doc, you know, those NSAIDs, they hurt my stomach, my GRD, I can't handle that. Do something for me. Well, okay, let's go ahead and give them some Medrol dose pack or put them on the IM injection either. Be careful, you can jack them up. You can jack them up. You know, a lot of times, in like a big man, you can get away with it, but I think for the most part, unless you are really in control of their sugars, wouldn't go there. Okay, I just come up with something else, you know, because and it's not like, well, it jacks up for a day or two and then it goes back down. It doesn't work that way. It's kind of a long, or a week or so before it goes down. And if they got some other things going on at the time, that could take them over the edge and put them in the hospital. So that's not a good thing, all right?
What's the name of the cream that you recommend for the joint pain?
The Zostrix HP, which is just basically, capsaicin, yeah.
And it's over the counter.
Yeah, so, you know, that cream was initially, Zostrix HP, it was initially made for people who had the herpes, and it helped, believe it or not, and stuff stings.
It
and
does
yet,
sting, but
you would put it on her, and they found out that once they put it on their joints, it kind of helped their joints, so we use it. Now, it's not a cure-all, obviously, but it helps.
If you inject their joint, that usually doesn't raise their sugar though, right? 'Cause it's not-
You can't, that's what I'm saying, even if you inject the joint, because
It will
even intra-articularly, if it's, especially if it's a delayed, you know, and most of the times for like chondromalacia and some of the epicondylitis when you inject, I always take about 1 cc of the fast acting and then 1 cc of the long acting, because you want to, and so that can make a difference. Now, if you use a very minimal, small joint, probably all right, but a knee, hip, something like that, where you got to, use the lidocaine on top of that too, I'd be very, very careful, because I really have seen people's sugars jump up. Yeah, so that's a problem. The thyroid hormone can actually be a problem when they're taking that and they have diabetes. It can actually jack up their diabetes sometimes. So if you're titrating thyroxine and you're trying to control their sugars too, you may do one first before you do the other. Okay, you might want to do one first before you do the other, because it's all like a tug of match. It can be. Now, I haven't personally seen that, but I've been told that can be the case. Okay, we talked about the beta-adrenergic agonists, that they're good in some cases. I wouldn't use the plain Inderal or propranolol. Would not use that with a diabetic. But some of the other ones, Toprol, metoprolol, some of those are really, especially if they have heart problems, macrovascular problems associated with it. It's okay to do that. If you add an alpha blocker on top of that too, like labetalol, that also helps. A lot of times you get, what is that new drug? It's not really new, but we use it like Cardidil. Yes, it's a very good, in fact, that drug was actually formulated to be used with diabetics resistant to other medications. So that's a good choice to use, but be careful with it. And that's a BID. You have to take a BID on that. So, but Dilantin, believe it or not, Dilantin does everything. That interferes with that, what do you call that, P450 system and that CY cytochrome, whatever that stuff is. It affects erythromycin, quinolones, theophylline, you name it, there's a problem with it. So, but it's a good seizure drug. It's a good wastebasket anticonvulsant. The first person that comes in and says, well, You know, I've been told I have seizures, but I haven't had them for years. Well, you are. I'm on Dilantin. How long you been on it? Oh, 20 years. You know, hey, it's doing something. It's keeping them from seizures. So it's going to be with you. You're going to have to use it, but just be aware of it. Be aware of the side effects. Quinolones, floral quinolones especially, they can cause some problems for some people. Metformin, lab test for metformin. Why is it important to take a lab test with anybody on metformin from 250 BID to 1,000 BID max? Liver or kidney? Both. What's more important?
Kidneys.
Why? No.
Metabolic syndrome.
What?
Metabolic syndrome. Metabolic syndrome.
Metabolic syndrome meaning what is the big thing that every big red flag for testing metformin? Absolutely. And if you get lactic acidosis, what happens? 50% of you are going to die. And there's not a darn thing anybody can do for you. I remember in Dallas, I had a case. I worked for an insurance company on the side of the docks. Did that to make extra money because they don't pay us a lot at the metals. And we had to do other things. And,
Don't worry, you know how you feel.
you know how that goes. And they won't let us moonlight, so we don't do it. Anyway, this doctor had put this woman on metformin for diabetes. They just told her that you need to be careful on that. And she was non-compliant. And, he didn't do timely creatinine and creatinine levels. And so she ended up in the emergency room, and they thought it was ketoacidosis big time, called on the whole bit. And the lab, pathology lab, found out that it was lactic acidosis. They went back, looked at the records, found out she was on metformin. Next day, he was sued big time. And it was not a whole heck of a lot I could do about it, because he hadn't done proper, even though she was non-compliant, he hadn't done proper lab values. And he was still filling them, every other month. Well, I'm out. Well, how you have your secretary go ahead and call it in. Come in. Didn't come in, but filled the medicine. Come in. That's what happened. Attorneys don't care what problems you had. They just know that you caused it. All they care about. I hate them. I really do. I'm serious with a passion. I do, because it's ridiculous. But we the public, we allow that. Trial lawyers to get away with that. Especially when it's things like that. They ought to look at that doctor's record and see how has he cared for his other patients, or he or she. And if it was exemplary, that should be considered. Do you think they care? You think they care about that? You think they care what you all going to do outside of that patient that sues you? Nada, nothing. So you got to be careful, and you may have to be a little mean and say no. You don't get any more unless you come in. Now they may complain. Some of them have even called the board on me for doing that. Yeah, they've actually called the board on me. But you're on the right side there. You're telling them. Then you send them a certified letter, and then they're out the door.
So
yes, ma'am.
How frequently do you check the lactic acid on a person who's taking metformin and is pretty much controlled?
Good question. It's controlled. They're not. The liver function tests are normal. You're bringing down. I assume, what is the hemoglobin A1C? What is it?
Say 6 point something.
6 point something. And what dosage are you on?
We could say they're taking 500.
500 BID. You're in good shape.
Yeah.
In that
You can
situation,
do it like every 6 months, maybe.
after they've been on it for at least, I'd say 8 months, you can probably do that. But remember, most of those type of people may have dyslipidemia, where they probably on a statin too. And so you're still going to need to do LFTs. So when you do that, that's one of those cases, people, where it's prudent to go ahead and add the BUN and creatinine on there.
Right.
So it doesn't cost hardly much more to do that.
With kids, I'll always get a CMP, which will have your liver function
Yes.
test, your glucose in it. When I'm anytime looking for metabolic syndrome, you'd be surprised how much fatty liver you'll find in kids by doing that. But then you can use metformin down to 12, and they're actually allowing statins. I think the latest I heard was down to 8
Is
for
that right?
familial.
Wow.
Those are the patients you bring back every 3 months automatically, right? They don't get their refills till they come back in.
Right, theoretically. Although there are lots and lots of practitioners out there that are seeing them every 7, 8, 9 months.
Really?
And they're tons of them, yeah.
Down to 12 years old?
On the metformin, yes.
500?
Start at 500 and then titrate as needed. And we need to make sure they take it within the month.
That's really interesting. The metformin, the Januvia work pretty well because you don't bottom them out. That's
You
another
don't have
thing.
that.
With the sulfonylureas, you gotta watch it with either one of those because you can bottom them out. Whereas you don't have to have that problem with, and also with the Avandias and the Actos.
Plus the
Remember,
Januvia can help them lose weight also.
absolutely, yeah. And metformin is weight neutral.
Also, right.
So it's a win-win
They're not gonna
thing.
gain.
It's expensive though. And again, you know, and if I usually I'll start them off in a combo. Right, maybe 550 BID. If let's say the hemoglobin A1C was 7.8 or higher or something, then I would probably go with a combination as opposed to just metformin or just opposed to a sulfuria or just what. And I've hardly ever just use a triglyceride by itself. I'll always have that with something.
Although plain metformin is on the Walmart $4 list.
Yeah, it's a good thing. I'm sure they don't have Januvia though, right?
No.
Is there some way we can get that?
Yes, go online. It's online. And what is Walmart is Safety's also. Yeah. If they're on the East Party side, yeah.
And actually, they have 90 days supply on their phone.
Yeah, $10, right.
They got a lot of good stuff, but you know, do they have potassium supplements now or not?
Yeah,
They
yeah.
used to didn't have that.
They-
So you can get them now?
They've really expanded the list, which is
Oh.
helpful.
Yeah.
But they
Excellent.
only have, as far as I know, one oral liquid antibiotic, which is namoxil.
Right. If it's not generic, it's not on the list.
Zithromax has gone generic and it's still not.
Right, and
That's
Augmentin
true.
is still not generic, so it's not on
They
the
have
list.
Augmentin for adults, not for kids.
No,
Not for $4. I just checked, my son had
Are you sure?
skin infection last week and I went and it was gonna be $69.
Was Walmart? Maybe it was one of the other ones, because I'm pretty sure that.
Because the doctor keeps sending people to the pharmacy for $4 Augmentin, and the pharmacist keeps telling me, we don't have $4 Augmentin. Will you tell him?
Not for order.
Somebody said that the other day.
although my parents have gotten very creative at crushing and mixing.
Hey, everybody else. My mom included there. Thyroid. We'll mention about thyroiditis. You know, you got Hashimoto's. That's the only thing that's the most common autoimmune. Often, if you see a goiter and it's asymptomatic, patient's asymptomatic, is Hashimoto's until proven otherwise. But you can also have the granulomatosis subacute, you know, which is caused probably by some type of viral, which could be the cytomegalo, EMV, any of those things. We don't really know why. That's usually painful, and they have a hard time swallowing. And that can usually lead also to hyperthyroidism. Then the course progresses to hypo, and then you get euthyroid over time. But in the meantime, you may have to treat them for the symptoms of hyperthyroidism, which would be what?
Everything's running hyperthyroidism.
And what are some of the symptoms?
Sweating,
Exactly. And what medication would you give them strictly for symptomatic? You said yourself. I hit it with my professor said that to me, so that's why I knew it. Propranolol, absolutely. You guys are on top of it. You guys are on top, absolutely. But you always start with very, very low dose, go up. Don't start with a high dose just because they have massive symptoms, because you'll mess up. Start very low, you have to have them keep coming maybe, or you tell them to titrate a little bit every 3 or 4 days, but you start low, build up. Start low, build up.
When do you use a PTU if the patient is symptomatic? Why don't you use the PTU versus the Indra? I know the recommendation is
For
Indra.
hyperthyroidism?
Uh-huh.
You know what? I'm going to be honest with you. There are a lot of general practitioners that feel comfortable with that. For me, what did I write about that? Yeah. Methimazole, trapazole. That is actually the first line. okay? You're talking about 15 to 60 milligrams daily on that. The propylthyroid uracil, you gotta be careful in elderly heart problems. It can cause arrhythmias. You gotta be careful in cardiac people. And it's probably the drug of choice for thyroid storm. Other than that, I'd probably go with what are you worried about?
Also,
Okay,
pulmonary
Yeah.
obstruction and
You read it, the carotid, I always said I scrubbed in on it, but I read it to me, and you read the
Really?
carotid.
Okay. But what's even more common than that?
surgical,
Due to,
Swelling.
due to,
surgical,
due to, due to,
radiation,
due to,
excision,
excision due to
the
laryngeal recurrent nerve. They nick that nerve. It's right by the thyroid. Remember, that could be a board question, folks. That's why I wrote that down. I missed it, okay? So recurrent laryngeal nerve. Recurrent laryngeal nerve. That's the major reason. And then they walk around, can't talk to them. So you really don't want to do that unless you just have to, or unless it's obviously malignant.
Because when they're doing surgery, they always make sure they get them, the nerve, and then they.
Yeah, they're supposed to, yeah, but I mean, things happen, you know, especially in an obese and a short, no-neck person, it's hard, let me tell you, it is difficult. That very, very little neck, it's very, no, seriously, it's difficult to get in there, even with the smallest hands, so.
But if they have a goiter, then they're gonna get their thyroid removed anyway.
Yeah, but they're usually gonna ablate it though.
Yeah.
Radiate it, just radiate it.
And I had mine rated isotope, and you know, you just need to keep away from people for 7 days.
Yeah.
And sleep alone for 7 days, wash your clothes
Right.
separately,
Mhm.
brush your teeth, and then you need to rinse the sink, and
Wow.
not be around any children.
How was it? How was it, the
It was fine.
convalescing?
Nothing, it was fine, it was just 2 big pills, and that was it.
Wow,
Yeah.
that's amazing.
But then you go very bad hypo right away.
Oh, yeah.
And then you feel that people at
Oh,
work
yeah,
that-
you
that's-
crash.
I met a lady that said it was the worst thing.
Yeah.
It was a big change in how you
Yes.
feel, and it was the worst.
Because it's very
worst ever.
sudden.
Yeah.
Yeah, that's
You
true.
lose hair, you lose your hair, I had like a 1 inch hair
Right.
line, and yeah. it was
Yeah.
bad.
But you know, if you prophylactically try to look for that, it start people on certain things like that. Like, you know, like I said, you have to use beta blockade initially, and then turn around and put them more maybe on a little higher dose of thyroxine. And I think you can eliminate the major. Now, in the elderly, where they have arrhythmias and you know, kind of carpal tunnel and stuff like that, that could be tricky. So I don't know. I think probably the medical way of using the PTU or the methylmazole would probably be more effective. Although I've been told that's only like 75% effective. A lot of times you still have to go in and do something, but at least it'll buy you time. So you know, something to think about on that. On the thyroids, though, of course, the main things that you want to get, you know, everybody want to get your baseline TSH. I already alluded to that. But, you know, I found out that, you know, you can order T4, T3, and all that other stuff. But really, you know, if they're subacute, if you get a TSH that's increased and then you get a normal T4, you don't really need to mess around with a T3. You know, you go with what, you know, you can save money and pretty much treat them like that. You don't have to worry about all these autothyroid antibodies and stuff unless it's a really complex, lawyers type thing. And most of the time you want to send that out, you're going to refer that out anyway and let them order that. So, you know, the basic thing, if it's severe, you're going to have to check, you're going to have to look at anemia, because a lot of people will have anemia secondary to the thyroid. There are a lot of times their cholesterol may increase, especially the LDLs, they'll go up. They may also even have hyponatremia, believe it or not, because you know those little iodoform, the iodine on there, it's an electrolyte, so it kind of replaces the sodium a lot of times. So that sodium transport system, the ATP and those, you know, the stuff you learn in biochemistry, it comes into play there. So sometimes you can get hyponatremia. You can also get increased CPK, LDH, and ASTs. Not always, but you can get that. And so you may be thinking something totally different, and it's the thyroid. So be aware of that, and be mindful of that. Hypercholesterolemia, serum cholesterol greater than 200 milligrams per deciliter. Look for associated conditions. Obviously, we're talking about atherosclerotic disease, hypertension, obesity, possibly diabetes mellitus type 2, familial hypercholesterolemia, ask for family history if that's important, you know. All those things lobbed together, you know. I think one person mentioned that we call it metabolic X, the metabolic X syndrome. You know, that's very, very, very prevalent here in El Paso. You all know that. It's probably one of the most prevalent, you know, illnesses that we see around here. But also in Dallas, I mean, just rampant, especially in minorities, you know. Hispanics, African Americans, Native Americans, don't even let me talk to you about that. I had the pleasure of being medical director at the Dallas Tribal Center, which were mostly Choctaw and Sioux Indians, pure, you know, full blood. And they were under the Department of Interior. And it was unbelievable. Triglycerides were running 2,000 to 3,000. And that was normal. That was normal for them. I mean, they were asymptomatic. Right? LDL is off the wazoo. I mean, unbelievable. But, you know, their diet, you know, they have that fried bread that they make. They dip it in oil, and it's delicious. It is delicious. I gotta admit that, but it's my goodness. So we used Actigol at that time, you know, that medicine, Actigol, would break up the gallstones and stuff. And we got donated a nice little ultrasound machine, but it was just unbelievable. But the amount of diabetes that came out of that was absolutely just astronomical. So, you know, that's very, very important. Be mindful of your population. You know, you just, even if they look like the picture of health, it's those skinny ones that sometimes scare the devil out of you. Believe me, it's the skinny ones that scare you. So that's always important to remember. LDL, as everybody probably knows, is calculated, and it's only accurate if under fasting conditions. So don't be ordering an LDL and thinking, you know, somebody is non-fasting thinking that it'll give you an idea. Don't waste your time. And if the triglycerides happens to be over 350, 360, forget it. You're not going to get an LDL anyway because of the accumulation of the fat droplets there. So you got a problem there. TSH is important, as I said before, with thyroid, to get that as a screening when for hypothyroidism in lieu of hypercholesterolemia. Medications, basically, I'm not going to get into that too much. The statins are probably the first line. You have to watch liver disease. Everybody knows that, but people are really becoming kind of slack. I remember when I was really treating that, I had them come in at least every 12 weeks. Every 12 weeks for the first year. And then after that, their liver functions remained baseline, didn't go up. Then I told them they could come in every 4 to 5 months. Not every 6 months. I don't like every 6 months. That's too long. But every 4 to 5 months. And I'd get them then. And then maybe 9 months after line. If they've been on it 2 years, then perhaps you could drop down to 6 months. But sometimes those will scare you. The less call, be careful with that one. That's the only, I believe, the only synthesized statin, HMGCO. And sometimes you can get some effects with that one. It's also the cheapest one. So think about that. You know? So people may ask you, well, putting on this costs cheaper. So you might want to look at that if you're already concerned about liver function. An individual that has liver function tests and you do a baseline, you always want to do a baseline, and let's say they're 30, 40% increased. I didn't say 3 or 4 times increased. I said 30, 40% increased. But then you have to weigh the risk versus the disadvantages versus the advantages of putting them on a statin if their cholesterol is high and if they've got other things that you're worried about, like the heart disease, atherosclerosis, whether or not to put them on that.
Do you ever do every other day statins?
I haven't, only because the literature doesn't verify that, but I know some people that do. And I'm not sure if that makes a difference. I don't know what the half-life, I mean, you know, if that makes a difference on that.
Well, my husband was on Pravachol for a long time. He did it every other day.
Was his liver insides a little high anyway?
He bumped his LDH the first month he was on it, and then once he went to every other day, his cholesterol stayed at 168, and his LDH came back down. So
is that right?
Yeah.
Interesting note there. You know, I've never had anybody on alternate day. I either put them on daily or I start at a very low dose. But you know, they have those graphs where you can look like if you use, I like to look at Lipitor. I think that's my favorite. If you look at how much you want to bring it down, you know, you can look at how much it rises, 10 versus 20 versus 40 versus 80. I can tell you with experience and by having so many reps come by and I quiz the heck out of them. That's how I learned. I learned by talking to the reps. Who the heck wants to read all these books? You've already been doing that. You're doing that now. You want to be doing that in practicing medicine too. Those of you who like to read, go ahead. Go for it. I don't. I get my knowledge from bringing in lots of reps. Yeah, it's biased, but I'm going to learn everything there is to know about that one drug. Right? Right? Plus I get a lot of samples, little things. And believe me, you gotta come up with these little things. It'll help you. You'll be surprised how it helps you out. Then they tell you, oh, this provider, they listen to me. Why don't you go by there and read this? Before you know it, you got a lot of samples there. That's the way you do it. But you got to give them the time. It's not. I mean, how many of these docs do you see? They're seeing a patient and they have their secretary say, oh, just leave it there and he'll sign off later. Just rude, absolutely rude. The big groups, I can name some groups here in El Paso, I won't, but you probably know what I'm talking about. To me, that is unconscionable. That is ridiculous. You should just set time, even if it's during a lunchtime or something, give them about 10, 15 minutes. And if you get into it, give them 20 minutes. Just figure it out with the patients. But if you're learning and if it's something that you're going to use, you benefit, your patients benefit, they benefit. You know what I'm saying? So, use your reps. Use them, utilize them. That's what I do.
And if you normally spend time with them, if you're having a really bad day, you say, you know what, today I just can't, they're okay with it. And they still leave you all the things.
Exactly correct, because they know that it's not. Yeah, absolutely. And I guarantee you, they'll do something nice for you if you allow them that. Now, those that keep the proverbial ones, they come in every other day and want you to checking on you and say, well, I called the pharmacy, doc, and we didn't see you write anything. Well, then now you got to deal with them. And you will have those too. But it's a good idea to be friendly with your reps. It's a good idea, I think.
Well, y'all's prescriptions will show under your doctor's number, so you don't really need to write it.
Yeah.
You can say you're writing it even if you're not.
Absolutely. Yeah. Some of
Right.
Well, like I said, the stats are very good. The biggest side effect of the stats, of course, other than the liver function rise, is myositis, exactly. And a lot of doctors rush to get them off it right away and never go back on it again. Don't do that. Don't do that. Take them off it for a week or so and try it again at a lower dose. And if they still have it, get rid of that stat and try another one. And before you just discount the whole class. That's what I would do. Usually, they'll do okay with one. Some people don't, but usually the patients will work out okay with one of the other stats. Just try it that way. Questions?
What if their HDL is good and their cholesterol is borderline 230, 240, and they don't have a family history?
Good
I
question.
think Big Pharma makes us believe that everybody has to have a cholesterol that's 180, 160 below,
Right.
and I don't know that that's true because some people need a higher level even for
Right.
functioning.
Right. If the HDL is pretty high and they don't have a significant triglyceride elevation,
Right.
I think you're right.
The
you got to
cardiac
look
risk
for.
is still gonna be low.
Yeah,
Right.
exactly.
If they don't have any other,
Other
As
ongoing
a nurse,
toward-
what would you do?
well,
This is
I do the diet teaching.
There you go.
There you go. Which is always best.
Because, the reps make us feel like everybody has to be on everything. And I don't
Exactly.
necessarily
No.
believe
You
that.
wanna have
Well, of course, that's their job. That's their
Yeah,
livelihood.
they're getting paid for
They're
it.
getting paid. No,
And
you're
how
absolutely
did you
right.
give them that 3-month trial with diet
Exactly. And there's no harm, like I said before, folks, there's no harm with telling them about the omega fatty acids. The only problem I've ever had with prescribing that stuff is some people say the oil, the little aftertaste. But hey, I can live with that. If you all can live with it, I can live with it, So it's virtually harmless, and it does help. It actually helps.
Well,
I can't sleep with that.
Really? Really? You
What
can't?
is protein?
Is that
Fish
right?
oil is-
Have you tried the Lovesa, the prescribed one, the
No.
pure?
See, that's
The Lovesa one doesn't make you smell like fish.
No, it
You don't
doesn't.
taste
It
like
really
fish.
does. You don't get
It's
that
the
after
ones you
fish.
buy at the health food store.
Yeah, see, that's what I'm telling you.
That-
They call it
yeah,
not
if you taste it in a fish and you smell.
And that's why you pay probably a lot less. See, that's our classic example, folks. Going to GNC and getting it thinking you're saving money. Classic example, real thing. I mean, with more purified stuff. So, but I mean, I think it's a good add-on. Cholestyramine, Questrad. I hate it, but some people have no other choice. So you have to give them the packets, and they'll get used to it. It does work. It's not quite as effective as the statins, but it's a good drug. In lieu of the fact that if they cannot take statins, the Questrad or Cholestyramine are good. They'll complain of gas and stomach problems and stuff, but generally they'll do all right. Niacin's another alternative, but at best it would probably just be a supplement to something else. And again, with niacin, the reflux and the flushing. But I already told you what you can do for the flushing, the aspirin, the aspirin. So that's always something. But if they have diabetes, be careful with the niacin because we talked about that. So I think last but not least, I don't know why I wrote this down. Immunodeficiency diseases. Sometimes you all, and the chances are, it would probably be you all that sees these people, because they will have gone to a lot of physicians and specialists, and they'll dismiss them as, oh, well, there's nothing we can do. We've done tests, we've done everything else, blah, 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 whatever. You need to live healthy or whatever, to get about 5 minutes. But they need, they need to be counseled, and that's where you all are, because you can give them counseling about why they need to eat right now. But immunodeficiency disorders is a disruption of the integrity of the immune system, which results in increased susceptibility to infections. And I know there are a lot of people walking around that have that's really not really properly diagnosed. First important thing is history. You need to ask about their state of well-being. Are they depressed? Do they have a dysfunctional family situation? Is there exposure to other tuberculosis? Are they going across the border where there might be TB exposure and stuff like that? I mean, you gotta ask that. Do they drink alcohol, drugs, tobacco? All right, you're gonna ask that. Do they have GAD? Do they look malnutrition? Malnourished? Cachectic? Do they have anemia? Do they have a family history of immune? Now, most people are going to say, what's that? No, I don't think so. But you got to ask the right questions. Did they get sick a lot? Were they always in the doctor's hospital for respiratory infections or stuff? Oh, yeah, I had somebody like that. Let me clue you on to some genetic thing going on. Okay? This book is very, very, very good. I recommend everybody get
Did you
this.
tell us not to be?
Pardon? But I'm finished.
Except for this one.
Be finished. Did you see what it
See, I
says?
thought finally.
5-minute clinical consult. You can give it 5 minutes. Yeah. All right.
We have that in our
Not
PDA.
PDA.
Do you really? Oh, excellent. Yeah. You see, you all are confused. I hate computers. By the way, I like to read when it comes to that. But this is a very good book, and it has the CD-ROMs, and you can get on there too. But it's really kind of good and kind of, once you pretty much narrow down what you think you want to do, if you want to go into that, I mean, it really is a lifesaver for me. And this is the new 2008 version, and it comes complete with this little CD or DVD-ROM, whatever you call that thing in there. Anyway.
I see you're not using.
Well, obviously I haven't worked on this. Yeah, that's true. That's true. But anyway, I mean, the labs you could order are just, I mean, for the premature newborns, obviously the chromosomal abnormal, for Down syndrome, to rule that out, sickle cell, diabetes mellitus type 2, uremia, nephrotic syndrome, vitamin, mineral deficiencies, medications such as the corticosteroids, immunomodulators. My Lord, if somebody comes in and says, I'm always sick. Oh, I see you have arthritis. Yeah, and I'm on Emeron and a bunch of other medications for the rheumatologist. He should know better. He should know. That's your answer right there. I mean, it's the medications. So then, you know, you have to diplomatically call them up and say, Doc, well, they're doing fine. The rheumatoid is being controlled. It's being controlled on this dosage. Well, yeah, but the patient's being ill all the time. Can we kind of work something else out? And sometimes you have to be diplomatic, but a lot of times, not necessarily their fault. They just oversee that. They overlook that. And the patient doesn't want to talk to them about them because they're the specialist. And I don't want to waste my money, waste this time. I'm just going to ask them about my problem here. So there's lack of communication. Lack of communication. So that's important, folks. But bottom line is, you know, if there's humoral deficiencies, that is the IgG, E, A, D. You have bacterial protozoan infections, chronic sinusitis, chronic diarrhea, fungal, viral infections. Labs, high percentage of immunodeficiencies will be discovered by CBC and differential with differential smear, believe it or not. It doesn't cost that much. You can do that. You can do that. There's nothing wrong with doing that. If you think you need to take it to a step higher, you can always go with the immunoglobulin levels, IgG, if it's IgA, if you think it's stomach problems there, gluten deficiency, whatever, IgA, IgE, if it's more atopic, or eosinophilic, IgM, if it's a rapid acute phase, and then they get over it, and they're fine, and then they get it again, it's an acute phase, you may want to look at that. These things are kind of expensive. Keep in mind, be mindful of the expense though. Be mindful of everything you order, look at the expense. If you can get them, like Kathy was saying, in a panel where they're cheaper, always go that route. Instead of singling out things, and I want that one, and I want that one. Cookbooking it like that, boy, you'll get that bill back, or the patient will get that bill back, and they'll come to you. Doc, you know, I appreciate what you did, but I've had them do that to me. And so they're a little bit less cooperative the next time you want to do something like that again. So be mindful of that.
I'm pretty sure it's the Quest Lab book that also will tell you what diagnoses you need to have in order to order that test and for it to be covered. So a lot of times that's one of your best resources when you're thinking about what you need to order.
Plus, if they have a high deductible on their health insurance, if you go to Quest and tell them that you're gonna pay cash, they give you a big discount. If you say, I don't have insurance, I'm a self-pay, they give you a big discount.
That's good. But a lot of people, I mean, but if you pay cash, you're gonna come up with, what, a couple of hundred or something like that, maybe?
It just depends on what you're
Depends on
ordering.
what you get, so, yeah.
Oh, your ones are free.
Antibody responses to previous vaccines is always a good question to ask. A lot of people, I mean, I always forget to ask that. Tetanus, pneumococcal, HE flu, diphtheria, you know, oh, I had a reaction to that. Could be important. Infection evaluations, doesn't hurt to do an ESR, especially if you're looking at some type of autoimmune or connective inflammatory disease. ESR is going to be elevated. Does it tell you what it is? No. It's non-specific, but at least it tells you there's an inflammatory condition versus maybe a psychosomatic or a somatic dysfunction, which is a myofascial lesion, non-inflammatory caused by just dynamically changing of the spinal column. It's an osteopathic term that we use a lot. So it can help. So in that case, it's worth doing. You know, get it, you know. Specific complement levels, very expensive. Know what you're doing. Make sure you research. Don't just do a battery of them and order everything and hope something comes out positive. Don't do that. Don't do that. Specific cytokine function tests, same thing, very expensive. Genetic analyst, oh my Lord, send them out before you go there. Unless that's your specialty and you know what you're doing, you know.
If you know you're going to, especially in pediatrics, the wait is so long. If I had somebody that I was sending to a rheumatologist and for a specific problem, I usually would call and ask what labs are you going to want, and then I'll go ahead and get them. So when the patient goes, they've already got the results, and that saves a trip to the specialist.
And do you do the same thing with like orthopedic? I'm seeing a lot of orthopedic right now because it's sports season.
Depends on the orthopedic guy.
Order an MRI or an X-ray or
Not-
whatever.
not
It
versus-
depends on who it is. If you send a child to us, an orthopedic surgery group, they've got everything there.
Yeah, they want to do their own, but I'm in Las Cruces.
They wanna
so-
make money.
Yeah.
So, and they only have one group, so they want you to get the MRI first.
Yeah, you
Oh, yeah.
you've gotta learn who to
Absolutely.
refer to
Yeah.
and what they want.
Absolutely.
And see, where I was, it was easier to go ahead and get them in with the orthopedist because I knew they'd get the X-ray, and if it was broken, take care of it. than doing it.
Right.
It was one-stop shopping in the Northeast.
Exactly.
There weren't a lot of options.
We're a little underserved up there, so we have to cast it ourselves in a week after the swelling goes.
Initial fracture care.
Yeah.
But anyway, you know, like I said, genetic analysis, analysis, chest X-ray, always very important. You know, I'll tell you.
But make sure they're not pregnant.
Oh, absolutely. You got the signs and everything stating that they should be. But although sometimes that
That's
doesn't.
part of your
that
history
happens.
test.
Yeah.
Yeah.
Anybody from 4 to 8.
Absolutely. And remember, if they got belly pain or chest pain, they get a UA too.
Yeah.
But seriously.
You can dip it for pregnancy.
But I will say this about that, and then I think I'll close, unless you all have any questions. But in terms of having practice, your own practice, you know, when I started back in '88, it was still the last few days, not even years, the last few days, where you could still be autonomous and you could hang out the old shingle, and as long as you were pretty good, you could afford to lose money because you would always make it back and you make up for it. And you cannot say that anymore today. You cannot do it unless you're a good business person or you have somebody in there that can do your business. She will testify to it. She'll testify. Anybody that's been in practice will testify to private practice. If you're in a group, you say, well, you don't have to worry about it, but you know they're probably getting something over on you. You may be getting paid well, but they're making a lion's share. So, I mean, it's 50 cents here, half a dozen in the other way. The main thing, the point I'm just trying to make, if any of you think about private practice, I think, that would be a wonderful scenario if you can pull it off the expenses. But back when I started, you could get a check, you could get an X-ray machine for a reasonable price, reasonable, used, and you could hire you an MA, and at that time we were paying them about $6, $7 an hour, I think, or less, and you could literally train them. Okay, this is how you do this is how you do this, and there was a book, or you could even send them to a school for what, a couple $100 or something like that, and they would come back certified. Can help you do that. Now, can't do it. You've got to send your MA to school $5 grand. $5 grand to pay for them to be certified, unless you're in there and you're pushing that button. Now, a lot of guys try to get away with it by just going in there pushing the button and make them do everything else. But it takes time away from you. You could be seeing patients, so it's a give and take. But that's just one incident, how things have changed. Number 2, labs. We all used to have a little CD counter and little things we could do. Almost a thing of the past. Even if you have the money to buy one, most insurance companies won't pay you because they farm out to the reference labs. So you see, that's more income that you're losing. The last thing I saw before I gave it up was I do a lot of ACMED, and so I had a physical therapy. Yeah, physical therapy. Well, physician, a DO, hands-on. Why should you have a physical therapy, right? No, wrong. Now, you got to hire or contract a physical therapist to come in and do your PT. Or if you do it yourself, you're going to get paid about a fraction of what they'll get paid. Can you believe that? I'm serious. So that means hot packs, the TENS units, all those things there that we know how to do as well as anybody now, it's been taken away from us. So you see where I'm getting at, and this is slowly happening. And more
It's the same
more
with
business
nursing. We used to do respiratory treatments and all that.
We used to
So
do
they had
dressing
respiratory
therapy.
Right. Now we have wound care nurses, we
Yeah.
have respiratory therapists.
First assists.
Yeah.
Oh, yeah,
Exactly.
absolutely, yeah. So, and so I don't know where we're going there, but, that's a lot of good revenue that's been.
Well, I learned today that you can give crutches to people, but they're not reimbursed. But if you do crutch training, but you have to be certified to do the crutch training, then you can get $150.
Yeah.
They don't just keep crutches in the clinic that they let them borrow and they bring it back?
No, we actually
That's what
buy
you
new
said.
sets and give them to them, but we found out we don't get reimbursed, so they have to sign a waiver. But if you do crutch training, but you have to be certified to do it or have physical therapy to do it, then you can charge them $150.
Isn't that something? Yeah. And if you do happen to do a lot of occupational or workers' comp, oh my
Yeah.
God, don't even get me started on workers' comp. But some of you all might find employment doing that, and what can I say? I mean, it's horrible. But with the workers' comp, you know, it's all about documentation. If you don't document, they'll find a million ways to hold your pay. Put it in escrow for months on end. So you just gotta know that paperwork, folks. You gotta know your paperwork. I mean, what can I say? Any questions about anything?
Yeah, and I feel like why am I doing this?
Oh, I
Look
don't
at it
want to
this
go
way,
forward with that. I don't
your
wanna go
piece
forward.
was a lot cheaper than medical school, it's just as well.
Let me ask you, but before I go, if I can ask a question, what are you all's feelings, Kathy, and everybody, about, you're hearing about on the East Coast and in the Northeast a lot, they're having like the Walmarts and some of these retailers, they're putting nurse practitioners in. What is y'all's situation? What do you think about that? I mean, do you think that's gonna be the coming trend? Is it just a fad, fade out? What, I
You know,
mean,
they have that in Juarez, in the supermarket.
really?
Like Walmart, they
Yeah.
have a doctor,
Is that right?
except that there's no practitioners there, but there's a doctor. So you pay a consultation for $1.50, and then you get the medications there. or,
Is
you
that
know,
right? One stop.
For the underserved, yeah.
I don't think it's good just because it's more fragmented care to me. If you don't have a PCP following you all the time.
Is that, but does that
It
become
doesn't
that
seem like
PCP?
people really
Well,
use it.
I don't know,
Yes.
does it, or is it just an episodic thing?
It's supposed to be
It's
outside.
It's supposed to be episodic. That's the way it's set up, so that when you give them their antibiotic, you can go, look, you're at Walmart and it's $4 over there.
Well,
Right.
it's a marketing game, I mean,
Right.
Walmart is the best about marketing
Sure.
and putting companies out of business.
Right.
Yeah,
Sure.
but if, as a practitioner, what is your legal liability if somebody comes
There you
in
go.
with a strep throat, but they're overweight, they're hypertensive, and you're pretty
And you're just
sure
treating their
they-
strep throat.
It's the same thing with
Yeah.
a health fair, you do a
Yeah.
screening form, they have diabetes, and you
So-
just tell them that and they run away.
Right.
Where's your liability? You should be following up on that.
And there has to be some follow-up,
I don't
make
know
sure
how I
they're
feel about
referred.
it.
Yeah.
I think the lawyers have kind of figured that out, where if you treat them episodically for a strep throat, and you find out you've got other obvious things, as long as you give them and you have a copy of that, I think they've got it, that kind of worked out a little bit, where you're halfway, of course, you can always be sued, you can be sued for anything, you
Well,
all
how
know
is
that,
it,
but.
think about it, how is it any different than the people that just walk in the ER and use the ER as an episodic care?
As a clinic.
I mean,
That- well,
yeah,
yeah.
working
They'll
ER
pass
for
it
years,
over
and
to
that's the
the
same way, I mean, just,
Yeah.
it's no different than a
It's no
five-star
different,
in
that's true,
Walmart.
that's
Or
true,
if you see them in urgent care, or
That's
in
true.
urgent care, and you see them once and you'll never see them again.
that's true,
So, I think maybe just the venue's changing, but the idea is still there,
I agree,
so.
I agree.
I see it as serving a need.
I mean, having grown up out there, you know, when you get a bad snowstorm, if you can get to one place,
Oh,
that's good.
oh, sure,
But I mean,
exactly,
you have a lot of lawyers and
Exactly.
exactly.
Yeah, exactly, that's the problem.
I think it's got its pluses and its minuses.
Yeah.
You're right there.
You
Yeah,
know,
I want
in
oil,
Idaho,
please.
I played and he would refer to me and I'd refer to him, and we had a great working relationship.
Well, the pharmacy can give consultation services.
Yes, they can.
So
And
why is
actually,
it that nurse
pharmacists are
practitioners
supposed to
can't?
give consultation on
They're
their medication.
They're
They're not
supposed to.
do
Well, I
that.
don't think that anybody's saying that nurse practitioners can't, but the question comes in like, if you're there, who's your physician overseer? In Texas, you have to have a collaborative agreement.
But you're
Yeah,
talking, but you're talking the East Coast, New Hampshire.
They have
you don't.
corporate physicians.
Right.
This is different.
Right, and in New